All right, guys, welcome back to Underground Science. In this video, we'll be talking about atypical hemolytic uremic syndrome. Okay, so let's go and get started. So this is relating to the alternative pathway of the complement system. So before we actually start talking about atypical hemolytic uremic syndrome, right, let's talk about the complement pathway, specifically the alternative pathway. So remember, regarding the alternative pathway, we have something called the takeover state. Okay. And what the takeover means is that the alternative pathway is constantly happening at a low level. Okay. The alternative pathway is constantly activated, right? Is constantly activated in a low level, right? That doesn't make sense. Let's just say constantly activated at low levels, right? That's better wording. So that's what the takeover is. So let's say we have C3b, I mean C3, right? Just pure C3 going in our blood, right? Constantly produced at low levels. Then it gets hydrolyzed. And remember, we talked about all this when we did the alternative pathway video, so go ahead and check that out, right? So then it gets hydrolyzed. Then factor B joins in. So we get hydrolyzed C3 joined by factor B. Then factor D comes in, remember, and cleaves factor B. And then we get C3 hydrolyzed, factor B. And then remember, factor D comes in and cleaves factor B into BB and BA. And BB is the one that sticks to this hydrolyzed C3. And then remember, we said hydrolyzed C3 combined with factor BB, right? Combined with BB is the liquid phase C3 convertase, right? So this is the liquid phase C3 convertase. So that, or write that on another color so we can see it, C3 convertase, right? And then we said what can happen now is like C3 that's normally floating can get acted upon the C3 convertase, get converted into C3A and C3B. And then let's say that in our tissue we have some sort of pathogen here nearby, right? Have some sort of pathogen nearby, then the C3B can go and plug itself on the pathogen. So we get our pathogen like this and C3B like this, right? And then we said that C3B can then, so then what can bind to C3b, right? Factor B. And then factor D can come in and cleave factor B. And then next we'll have this, right? Remember, we'll have the pathogen here. Once factor B gets cleaved by factor D, we'll have C3b. And then bound to C3b, we'll have BB. And then this becomes C3 convertase that's now on the pathogen. And then this can amplify the cycle, right? And convert a bunch of C3 into C3b and C3A, right? And then C3b we know is a good opsonin, but also C3b can come back and bind here again. So then you're going to have C3b, BB, C3b, and that's going to be C5 convertase. And then from there you can form the membrane attack complex, right? Remember, we talked about all this in the alternative pathway, okay, when we discussed the complement system. All right, so that's the basics of the alternative pathway, right? Real quick. Now, why is this relevant in atypical hemolytic uremic syndrome? Okay, so when we're talking about all this, right, what we have to discuss is why can't this C3b, remember, that gets produced via the liquid phase C3 convertase, why can't this C3b just go and plug itself onto the endothelial cells, right? And then C3b, and then C that can lead to the production of C5b, right? After C5 convertase gets made. And then C5b can combine C6, 7, 8, and 9 and form the membrane attack complex, right? So here's what we mean, right? So if we drew a big endothelial or a big blood vessel, right? And we drew a large endothelial cell like that. And remember, we have liquid phase C3 convertase, right? which will literally take C3 and convert it into C3A and C3B. So the question is, why can't C3B, right, just go and plug itself? Okay, so let's say this is C3B into the onto the endothelial cell, which is our own cell, right? Why can't C3B just go and do that? And then later, right, we have factor B floating. Factor B can come in, bind, then factor D can come in and cleave factor B. So then you get, right, factor B and cleaved factor B, which is BB, right? Because remember, factor D cleaves factor B into BB and BA, and BB is the one that sticks onto C3B. So then C3B and C3B combined with BB make C3 convertase, right? And then so that can start. So this is basically C3 convertase now. And then you have a cycle that starts to form where the C3 convertase can take C3 floating in the blood and convert it to C3A, C3B, right? Then C3B can go back and bind. So then you get something like this, right? So let's draw the new product here is where you have C3B, then you have BB, and then you have C3B again, right? And this is C5 convertase. And then from here, right, it's from here you can form the membrane attack complex. So C5 convertase, remember, will take C5 in the blood, convert it to C5b and C5a. C5b can then bind with C6, C7, C8, and C9 and form the membrane attack complex. So then we can form a membrane attack complex on our own endothelial cells, which can cause destruction of your endothelial lining. So why can't all this happen, right, to our own cells if we're making C3b in our bloodstream? So this is what's related to, or we have to talk about why this doesn't happen, right? And what mechanisms we have in order to prevent the formation of membrane attack complex on our own cells, and what goes wrong in atypical hemolytic uremic syndrome. All right, so let's redraw our blood vessel, right? Our large blood vessel, and we zoom in into one endothelial cell like this, right? So again, we have liquid phase C3 convertase, and then we get C3b from that, right? So let's say C3b binds on your own endothelial cell, right? This isn't good, all right? But let's say it binds. Then we said, right? So let's say we have C3b. Then we said factor B can come in, right? Factor B can come in and bind. Then factor D will cleave factor B and you get BB. So then eventually you have BB. So we have C3b BB, which is C3 convertase, right? Thankfully, right, we have factor H as a regulator. We have something called factor H, and it's bound to our cell surface, like our endothelial cells, for example, right? Our host cells. We have factor H on our host cells. Why? What is factor H and why is it there? Well, factor H is a regulator, and what it does is it helps decay C3 convertase, right? So remember, when we talked about this in the alternative pathway 2, in that video, when we did that separately, we have factor H, right? Let's say it looks like something like that, right? This is factor H. What factor H does is it goes to C3 convertase and it accelerates the decay of C3 convertase. Okay, so what it does is it tries to decay C3 convertase, whether that be um, through stopping factor B from ever binding to C3b or displacing BB, right? Whatever it is, it helps decay, right? It helps decay, accelerates, I should say, accelerates decay of C3 convertase, right? Because you don't want C3 convertase to be there because we saw that that can lead to the formation of membrane attack complex, which will destroy your own endothelial cells, which we don't want, right? So that's what factor H prevents the formation of the membrane attack complex. It accelerates the decay of C3 convertase. And then remember, we also have something called factor H. Or not, we just talked about factor H, factor I, right? Remember factor I with the help of factor H, can inhibit, right? So factor I, let's write it here, factor I, with the help of factor H, can inhibit C3b formation and C3 and C4b formation, right? Which is also important in terms of reducing inflammation, right, on our own cells, like reducing the formation of membrane attack complex, right? Because remember, C3b, you need C3b to bind onto C3b BB to form C5 convertase, and then from there you can form the membrane attack complex. So if you can inhibit the formation, right, or cleave C3b, then you help reduce the formation of the membrane attack complex on your own endothelial cell, so you don't start lysing your endothelial lining, right? So that's the regulators and the mechanisms we have of preventing the complement system from occurring on our own cells. Now, in atypical hemolytic uremic syndrome, you have a genetic mutation or autoantibody against factor H or against factor I, for example. Now, imagine if this happens, then whether it's an autoantibody or whether it's a genetic mutation, that means factor H won't work or factor I won't work. So if you have an autoantibody against factor H or genetic mutation where factor H doesn't work properly, then you can think about what happens, right? You can no longer decay C3 convertase and prevent its formation on your own cells. So C3 convertase will then freely form on your endothelial cells, which will lead to the formation of many membrane attack complexes and which will lead to the lysis and destruction of your endothelial cells, which means your endothelial lining will be destroyed and you're going to have endothelial damage directly due to your own complement system that's unchecked. Okay. And then from there, we already know the pattern for certain things like hemolytic uremic syndrome, right? As we discussed in the previous videos, if let's say this starts happening, right, and you get destruction of your endothelial cells due to formation of membrane attack complexes, right? We know endothelial damage triggers what? Clots, right? Microthrombi. So if you have many small blood vessels, right, especially again in hemolytic uremic syndrome, it's blood vessels supplying your kidneys, right, and blood vessels in your glomerulus. If you have many microthrombi forming due to the widespread endothelial damage because of unchecked complement system, right, that's occurring on your own endothelial cells due to some sort of genetic mutation that's that's resulting in decreased function of your factor H and factor I, or an autoantibody, which results in decreased function of factor H and factor I, whatever it is, you're damaging your endothelial cells. If you damage your endothelial cells, you trigger microthrombi formation, right? You're forming all these microthrombi. So one thing you see is, right, microthrombi formation. So let's say that widespread microthrombi formation. And we know in our previous video, when we talked about hemolytic uremic syndrome, we said that this affects the kidneys more, right? So this is what mainly occurring in the blood vessels in your kidneys, right? Or blood vessels that supply your kidneys and blood vessels like your glomerulus, okay? So you get microthrombi formation, many of them, right? Because you're getting a lot of endothelial damage, right? Because you can't control your complement system anymore in your own cells. But if you're forming all these microthrombi, what are they made of? Platelets. So if you're using a bunch of platelets to form all these little microthrombi, that means you're going to have thrombocytopenia, right? Low platelets, because you're using them up. So then you can see your classical skin and mucosal bleeding, right? Skin and mucosal bleeding. Let's write it for both. So skin bleeding, like what? Like ecchymosis purpura petechiae, and mucosal bleeding, like epistaxis, GI bleeding, hematuria, hemoptysis, and menorrhagia, right? There's many types of mucosal bleeding that can occur. And because of these microthrombi, as we're familiar with, red blood cells that are in your blood vessels can do what, right? They're going to shear across these microthrombi and lyse open, leading to schistocyte formation, right? Schistocyte formation. Okay, so then you're going to get schistocyte formation, right, due to the shearing of the red blood cells. Okay, and Probably been spelling this wrong this whole time, but this we get the main point, right? You get schistocyte formation due to the shearing of your red blood cells. You can see this in the peripheral blood smear, right? So remember, helmet cells is what you would look for, which are the schistocytes. And because you shear this is you're gonna that's why you get microangiopathic hemolytic anemia, right? So you can also see an increase, or you can also see jaundice because when you shear these red blood cells, right, some of that hemoglobin can make it to your spleen, get metabolized and broken down, and then from that you can get indirect bilirubin, right? And we know indirect bilirubin, if it builds up, can lead to jaundice. All right. So that's those are the main findings, just like we saw in a hemolytic uremic syndrome in the previous video, right? An atypical HUS, though, it's the same thing, right? After you get endothelial damage, you form microthrombi, especially in your glomerulus and blood vessels supplying your kidneys. Because you're making a lot of microthrombi, you have thrombocytopenia and skin and mucosal bleeding. Then the red blood cells that are in your bloodstream get sheared and lysed open due to the microthrombi. So you get schistocytes, right? And microangiopathic hemolytic anemia. And then that's basically it, right? So, and of course, if this is happening in your glomerulus, for example, you can also get acute kidney injury, right? So your kidneys can get injured. Okay. And then, of course, if your kidney gets injured, right, this can lead to elevated creatinine, right? This can lead to hematuria. This can lead to proteinuria, right? Like if you're imagine if your glomerulus is all injured, right? The endothelial lining is not is damaged, right? Then things won't be able to filter properly, and you can get leakage of protein, right? Into your from your glomerulus to your Bowman's capsule, and then therefore into your urine. Leakage of red blood cells, right? And then you won't have if you're forming a lot of clots, right? And lysing red blood cells. Remember, your kidneys also need oxygen, right? So if you're lysing red blood cells a lot, then you're destroying red blood cells, then therefore you're basically reducing the amount of oxygen given to your kidney cells, right? To your cells that to your tubular cells, for example, which means that your tubular cells or your kidneys in general won't be able to excrete creatinine properly. So you can see elevated creatinine, you can see elevated urea, right? And then you can even see a low GFR, right? And if you see a low GFR, which indicates kidney damage, right, this can lead to the activation of your renin-angiotensin-aldosterone system, which can lead to a lot of angiotensin 2. And we know angiotensin 2 can lead to hypertension. So you can see hypertension also. All right. So if we talk about labs, right, real quick, what are the things that we can expect to find? Well, you're lysing your red blood cells, creating schistocytes. So that means you're leaking a lot of hemoglobin out into the bloodstream. So that hemoglobin can go to your kidneys, right? And then you can pee it out. So that's hemoglobin urea. So you can see dark colored urine, dark brown colored urine, right? And then all that hemoglobin, right, you have haptoglobin in your blood, right? So remember, haptoglobin can bind onto the hemoglobin and take it to your liver and clear it away, right? So that leads to, and your liver will clear that away. So all these mechanisms is to reduce your hemoglobin, free hemoglobin levels, right? So in labs, you can expect to find decreased hemoglobin levels, right? In addition to that, you can also have platelets. I mean, what are instead of wording it like that, right? If we looked at the platelet count, would that be high or low, right? Remember, you're forming a lot of microthrombi. So in order to form that, you use up platelets, right? Platelets are forming the microthrombi. So you're consuming platelets. So you would see low platelets if you saw the platelet count, right, in your labs. So your platelet levels would be really low, right? Because you're forming all these widespread microthrombi. Now, again, you're lysing your red blood cells, right? Because this is a microangiopathic hemolytic anemia. So you'd see an increase in LDH, decrease in haptoglobin, right? And then obviously, if you did a peripheral blood smear, you would see schistocytes, right? Right, helmet cells. Okay. And then if you're, remember this is all happening in your blood vessels that supply your kidney and your glomerulus. So of course, if you're getting microangiopathic hemolytic anemia in these blood vessels, you're going to get kidney injury, right? Acute kidney injury. So you can see things like elevated creatinine, like we talked about, elevated blood urea nitrogen, maybe even decreased GFR, maybe oliguria, right? Decreased urine production because of the damage that's happening to your kidneys. Okay. And remember, in this atypical hemolytic uremic syndrome, you're getting a lot of activation of your complement system, especially the alternative pathway. And what are you consuming a lot of? You're consuming a lot of C3, right? Because you don't have any mechanisms to degrade your C3 convertase, right? Because you don't have factor H. For example, you don't have functional factor H, like we talked about. So C3 convertase can take a lot of the C3 and break it down into C3b and A. So you can see decreased C3 levels, okay, if you tested for that. And last but not least, right, if you tested for your PT and PTT, are the coagulation factors affected anywhere here? They're not, right? So the PT measures the extrinsic pathway activity, right? So factors 3 and 7. Remember, the PTT measures the intrinsic pathway activity, so like factors 12, 11, 9, and 8. So none of these are affected. So that means the PT and PTT would be normal, right? Just the bleeding time may be elevated because of the low platelets. All right. So that's basically it, right? That's the main findings for atypical hemolytic uremic syndrome. A treatment that we can be familiar with, okay, when we're talking about this is a monoclonal antibody. Okay. And so this monoclonal antibody is actually called eculizumab. Eculizumab. Okay, eculizumab. All right. And so what is this, right? It's a monoclonal antibody that binds C5. All right. So if you bind C5 with a monoclonal antibody, remember, what do you need to form the membrane attack complex? You need C5 through C9. Well, if you bind the C5, then you can no longer form the membrane attack complex, which means what? Less endothelial destruction, right? And then, of course, you can do plasma exchange also, right? Like plasmapheresis, and remove the autoantibodies against factor H, for example, and then that would help too, right? But and then of course, if your kidney injury gets too severe, you can also do dialysis, right? So these are the basic findings that and the basic things that we needed to discuss for atypical hemolytic uremic syndrome. All right. Hope this video helped. I hope it made sense. Hope it wasn't too confusing. Thank you guys for watching and see you guys in my future videos.